I'm Dr. Iraniha. I'm a general surgeon, laparoscopic and robotic operations. So this is really an honor. It's a pleasure to be here. I know that Saturday is not a good day. We wanted to be outside, enjoy lunch with family, and for me, actually, it was very important. The only day I could spend time with my family. But again, they asked me to come here and talk to some of the patients, and I thought actually maybe some of the physicians in here too, but maybe next time. Anyway, thank you so much for coming. The reason we picked up the gallbladder disease is obviously very common problem, and at times is actually undertreated, underdiagnosed, and sometimes even mistreated and misdiagnosed. So there's a lot of issues about gallbladder problem that we're going to touch on those in this conversation. Before I go and talk about gallbladder, how do I go back? We'll just go back. So I want to tell you who I am first. I actually born and raised in Tehran, Iran. I did my medical school actually in Tehran University, and came to United States in '94. Went to Harvard, UCLA, and UCI local, and did my general surgery training. Since year 2000, I've been in practice, so almost 15 years now. Most of my interest is laparoscopic and robotic operation. We call them minimally invasive surgery. But I'm a general surgeon by training, so we do a lot of different things. From the top to the bottom, we do a lot of soft tissue problems like lungs and bumps and cancer of breast. Everything in the abdomen is related to us, like a gallbladder and appendix and colon surgeries and stomach and spleen. There's a lot of variety of things that we do as a general surgeon. So, now, this one? This one? The middle. So what is the gallbladder? The gallbladder is a tiny little structure right underneath of our rib cage in that area on the right side, right upper side. And it's a tiny little structure that is attached to the liver right here. So I wanted to give you a little tour, if you can turn on this, a virtual tour of the abdomen. If you don't get grossed out, I hope. So this is just a true gallbladder liver. It's a little dark here, you can't see. This is the abdominal wall, the rib cage you can see. Liver. It's dark, right? You able to see at all?
Yes.
So that's the diaphragm on the right side.
So it's like this. How are you when you're doing?
I'm with a telescope inside the abdomen, so you know sometimes it's nice that this is the large intestine. This is the left lobe of the liver. That's the stomach right here, and do you know what that is?
No.
It's pumping. That's your heart from the other side. So that's the diaphragm on the left side. But in reality, the gallbladder is attached somehow to the liver and the structures in that area. I'm going to go over that a little bit with you so you understand what gallbladder is and what that does. Liver is located on the right side of your abdomen, is right below your rib cage. It's actually protected with your rib cage right in that area. And liver is responsible to produce a juice called bile. It's a green juice that contains some enzymes and products that helps for the absorption and digestion of the food. Okay, that juice goes directly to this tube right here. That's called common bile duct, which is a tube that connects to the small intestine and brings the juice through the small intestine. So mixed with the food and helps for the absorption and digestion of the food. This structure is important because the pancreas gland also has a tube that is connected to this main tube, and they basically combine all of the juices that are required for absorption of the meats and proteins and fats and everything else. It's coming from these two major structures. So pancreas gland is located right in the center of your abdomen, the upper abdomen, behind the stomach. So you don't see the stomach right here, but that's the epithelium right in that area. So the gallbladder is like a little sac is attached to this main tube. Part of that juice, the bile that goes directly to the small intestine, is stored in the gallbladder. So the gallbladder function is like a little tiny storage in the body. And when you eat fatty foods or mixed type of foods, it contracts and gives you a little boost of the bile into the system. But it has a very, very minimal function in the abdomen. A majority of times, people, when we remove the gallbladder, they are fine with the absorption and digestion of the food. They don't need to be on any type of a special diet. And that's one of the things that are controversial. People outside, they think if the gallbladder is gone, they're going to have stay away from the fatty foods. In United States, it's a very common problem. Actually, in the world, it's a very common problem. Almost 5% of the men and 10% of the female, they have gallbladder problems. And in the United States, we just have 25 million people have gallstones. And around 1 million new diagnoses every year of gallstones in the United States. And 1.8 million people coming in with abdominal pain responsible to gallbladder problems. So as you can see, it's a very, very common problem. Just last year, almost 725,000 people go under gallbladder removal in the United States. Very common. Now, you might ask, why do we develop gallstones? It's very simple. Just imagine you have the water in the pool, not filtering it for a long time, and then after 6 months you come back and you look at the bottom of the pool, you see a lot of dirt, sludge, and mud. That's the same story for the gallbladder. Because it's a storage of the bile, some of the components of the bile precipitates in the gallbladder bottom, and they get together and they get dry, and then you develop the stones. You can develop multiple little tiny stones, or you can develop a huge, big mama stones, right? And so the idea why you develop the stones, you can categorize it in a very simple thing, two things. One is problem with the motility of the gallbladder, means the gallbladder doesn't empty itself, or is an imbalance of the chemical inside the body. Anything that happens, any diseases or problems that are associated with these two, they can cause gallstones. Now, we know it's very common in the female. Almost 10% of the female in the world and 5% of the men in the world, they have gallbladder problem, right? So, and it's something to do with the hormones, especially progesterone. That's why in the pregnancy also you have higher risk of developing gallstones, because progesterone decreases the motility and movement of the gallbladder. So they have more stagnant bile inside the gallbladder, so they can develop more stones. A lot of people even present during the pregnancy or after pregnancy with the attack of gallbladder. Obesity also has something to do with increasing the risk. And age, more than age 40, a lot of people, they have a higher risk of developing this. But you can have this gallbladder problem and the stones in the younger people population. The youngest that have done surgery is 14 years old, female. There's other problems that are associated with the gallbladder stones, also race. For example, in Indian American, the highest number of gallstones, Hispanics, and then less in African American. So that has something to do with the race too. There are other diseases that are associated with increased risk of gallstones, but the one that I wanted to tell you is a rapid weight loss also. People that go to rapid weight loss, mostly more than 20 pounds within 1 month, increase the risk of developing gallstones. And that's why people who go under bariatric surgery, the one that they go for losing weight, like a bypass operation, they have a high risk of developing gallstones or gallbladder problems. Okay? Now, how do they present? People with the gallstones, almost 70% of them, they don't have any symptoms at all.
Really?
So they're called silent stone. We call them a silent stone. And the ones that they have symptoms, they usually come in with bloating or indigestion after the diet, with reflux, or abdominal pain, whether right in the center of your abdomen or in the upper abdomen. Sometimes it radiates into the back or right shoulder. Some people say it happens around 30, 45 minutes after eating, and it lasts around 2 hours. But the most important thing for gallbladder is the episodic nature of gallbladder symptoms. It means it comes and goes. It comes and goes. It's like an attack. Sometimes you have one-time symptoms, and then after 2-3 months, you're fine, and then you develop another attack. Or sometimes happens every time you eat. Okay, so the episodic nature of the gallbladder problem is very, very characteristic of gallbladder disease. Now, we call this is a biliary colic. It's not a colicky pain at all. It's actually sharp pain or dull pain, mostly like a fullness people describe. But because it's a episodic pain, and people call it a biliary colic. That's just the name of it. And why is it comes and goes? Most of the time is related to the contraction of the gallbladder. When you eat, it contracts and it pushes the stone, and it causes a temporary blockage right in that area. So people get abdominal pain and all the symptoms, and when the gallbladder relaxes, the pain just disappears. And that's what happens. Now, there are other people, so almost 56% of the patients, the ones that they have symptoms, out of that 30%, 56% present with these episodic pain. But again, remember, sometimes you have one-time pain and you don't have any pain for 2-3 years, and then it comes back again. It happens sometimes. But once the stone completely is stuck in the neck of the gallbladder, it causes obstruction of the gallbladder, causes inflammation, infection, sometimes even gangrene, necrosis, sometimes even perforation. It's not very common in the gallbladder to develop a perforation like appendix, but I've seen it in my practice, probably few in the last 15 years. But majority of times you can get completely necrosis or black gallbladder and gangrene. Those people that develop the acute infection, almost 36% of them, they present that way. And the other thing that happens, sometimes the stone moves and falls into the main tube, that common bile duct that I was telling you, and it causes obstruction right at the end. It gets stuck right in that area. So then the bile doesn't have any way to go into the intestine, as well as the juice of the pancreas. So you get back obstruction of both of them, and that's the bile goes back into your blood, and that's why people present with a jaundice and yellow color in the eye. They can get liver inflammation, more abdominal pain, and sometimes even systemic infection. Pancreatitis is another complication of that problem. As I said, that when you get obstruction of the pancreas, you can get pancreatitis, which is very unforgiving, very, very bad problem. Because it's all those juices that helps you to digest the filet mignon and meat and everything is in the pancreas gland, right? So when you get obstruction, that juice goes out and eats up your tissue, so that people can get massive amounts of abdominal pain and problems. So those are, we call them usually the complications related to the gallbladder problem. Okay? Those people present with this abdominal discomfort. They don't have that complications, but when you get infection or pancreatitis, we call them a complication of gallbladder problem. So how do we diagnose it? It's very simple with the ultrasound. That's the first thing we do. And this is a view of the ultrasound. That's the gallbladder. You just have to believe me. And this is the stone in the gallbladder, right? So the stone in the gallbladder, a lot of these stones, they have components of the calcium deposits. So when they shine the ultrasonic wave, it doesn't go through them. So if you see that black shadow, the dark shadow, it tells you that this is not a tumor and it's a stone. Okay? So this person has one big stone in the gallbladder, and this person has multiple stones in the gallbladder. And you can't appreciate it in this right now because of the lighting, but there's a lot of shadow in that area. Okay? So that's how the ultrasonic technician that they look at it and they can differentiate the gallstones. The other thing that we measure the wall of the gallbladder. The gallbladder is like an onion skin. It's very thin. When you get inflamed or infection, it gets very thick. So when it gets thick, the thickness of the gallbladder wall is very important for us. We can say patient had chronic inflammation, even if they say they don't have any discomfort. Okay? Because sometimes the stone is stuck in the neck, just like the picture that I showed you. In this one stone is stuck in the neck, and you can see the shadow in that area also. And this one, these little tiny little structures inside the gallbladder, they're not the stones. You don't have any shadow, as you can see. Those are polyps inside the gallbladder. Now, we don't do usually CT scan for people with a gallbladder problem unless they have massive problem like pancreatitis or those complications that are related to that, or we don't know the diagnosis, it's very vague abdominal pain. We do the CT scan, and sometimes you can see very inflamed gallbladder. These are all inflammation again around the gallbladder on the CAT scan. So this person has an infection of the gallbladder. Now, the gallbladder disease is not always associated with the stone. There are people with a gallbladder problem that they don't have any stone at all. We call them a category of a biliary dyskinesia. What that means is the gallbladder doesn't function very well. It's lazy. It's abnormal. So they come in with the same signs and symptoms, but they have normal ultrasound. Okay? Almost 8% of the men and 21% of the female with gallbladder problem, they have normal ultrasound when we do the test. So how do we diagnose those people if they have symptoms? What I do as a physician, we do a diagnosis of exclusion. We have to basically rule out everything else that can mimic the same symptoms and signs before we subject the patient for surgery. So when they come to my practice, what I wanted to do, I want to make sure they don't have any other disease related to the intestine and the stomach before I make the decision for surgery. And most common problem is gastritis, reflux, ulcer disease, and gastritis. So those are the very common problems that can mimic the same symptoms. People who have inflammation of the stomach, if you do an endoscopy, you can see inflammation and redness in the stomach. The ulcer, you can see this patch of the ulcer that is eroded into the normal inner layer of the stomach. That's the ulcer. Or you can have called esophagitis or reflux disease, which is the inflammation of the esophagus. So the juice of the stomach, it goes back into your esophagus. People get heartburn, abdominal pain, and stuff like that. So the most important thing to diagnose that is an endoscopy. There's other problems that can cause the same symptoms, and people don't have none of these. It's called functional dyspepsia. That's very common, for example, in people who have diabetes. The stomach doesn't function very well. It's just a functional abnormality, okay? The inner layer of the stomach is okay, they don't have inflammation, but it doesn't function very well. So they still feel bloated and uncomfortable, sometimes reflux. And the other thing that can happen is the most common problem that, especially in the older population, is heart problem. So if people have a heart disease, they can also come and present with abdominal pain. So sometimes people get admitted to the hospital for rule out myocardial infarction, and then I get a call because they had a stone in the gallbladder and it was not a real heart attack. Right? So how do I diagnose them? Okay, how do I diagnose them? Every one of these have a little bit different as far as the pain. The pain character is a little bit different. So we usually go over that with the patient, so you always have to make sure you talk to your doctors and exactly tell them exactly your pain, the relationship with their diets and activities. So we have a little bit of differential diagnosis there. And then we do upper endoscopy to rule out these two problems. And then we do EKG, obviously we check the heart and make sure everything's okay before we make the diagnosis. Now, let's assume that all of those are negative for this patient. So you have a patient with a normal ultrasound, typical pain, and then also rule out other problems. So I did an endoscopy with a gastroenterologist and I did EKG and there's nothing wrong with the heart. And my patient is still symptomatic. I send them to another test, it's called HIDA scan. Okay, what that means is this, there's a little device, we send them to the radiologist, and there's a little injection with a radionuclide medicine. We inject that to the patient, and it goes and shine up into the liver. So the liver cells, they uptake that little medicine. So you see that little dark area, that's your liver. Again, you have to trust me, this is a liver. And then it excrete that material into that bile duct, those ducts that are telling you the common bile duct. And then all of a sudden you can see the gallbladder right here, right? So the computer measures the radioactivity in your liver, okay, and gallbladder. And then after we do that baseline radioactivity, we give the patient a little hormone called CCK hormone. It's the hormone that you and I, we produce after we eat a fatty food to contract our gallbladder. So then we actually, on purpose, contract the gallbladder, and then again, we measure the baseline radioactivity. Then we put them into the little formula and check the gallbladder ejection fraction. So what that means at the end is that it check and measure your function of the gallbladder, how strong your gallbladder emptied itself. So by definition, if they're lazy, if the gallbladder is lazy, inflamed, or it doesn't function very well, it doesn't empty itself. Okay, so there's a number that comes out, and that's a magic number of 35%. So if it's less than 35%, and patient has all of those typical symptoms and pain, then that's the time that I would say you need an operation, because 95% of those people, they respond to removal of the gallbladder and the pain will disappear.
Is CCK like fat and sugar?
No, CCK is a hormone. It's called cholecystokinin.
So is it like what really affects your gallbladder?
No. So sometimes in the past, when we didn't have the actual CCK available to inject, we would give the patients like milk to drink. So the milk or fatty foods and stuff, they activate your CCK is a hormone that we produce. Okay, and then we inject it. We have this is available right now that they inject it directly, and that causes it. The other thing that is these patients that they have gallbladder problem that have, if they have that pain when they inject the CCK in the radiology, that's very suspicious for gallbladder problem. We call it a biliary dyskinase.
Sure.
Now, what to do with the silent gallstone? So let's say my friend just bought an ultrasound and did a gallbladder ultrasound for me to say it's free, and now I have an ultrasound stone in my gallbladder. What do I do? Okay, so what do I do? Again, you know, I said 70% of the patients, they don't have pain, right? And a lot of studies done and showed that just 10 to 25% of those people in their lifetime, they can develop problems with the gallbladder. And majority of those people, they first start with some sort of a symptoms. So they get symptomatic eventually before they get complications. So that's why a standard of care right now is not to do surgery for those people, just watch them. But they need to know, they have to talk to the doctor, they need to go in and remember that they might develop these symptoms, and if they develop symptoms, then they have to go to the surgeon and get the surgery done. But, can you go back, I'm sorry, it's very sensitive. But there are exceptions on those people. So sometimes people coming in with the ultrasound, they have big, huge stones. Those people have higher risk of developing complications and infections right away. Sometimes people have a very tiny little stones, like a sands. Those, they can have a high risk of passage. They can develop pancreatitis. So those people are exceptions. We, as a surgeon, we identify those. Even if they're silent, they don't have symptoms, we operate on them. The other thing is called porcelain gallbladder, is gallbladder that is like a stone. It's like completely calcified. Those have a higher risk of cancer. If you have no symptoms, your ultrasound shows porcelain gallbladder, you still need a surgery. People who have polyps that are large, more than 5 millimeters, the polyps, those are growth inside the gallbladder. They're not a stone, they have no pain at all. They just did the ultrasound, they have mass, we need to do surgery. People who go for bariatric surgery, the ones that they wanted to do bypass operation, if they have a stone in the gallbladder, they need the operation, even if they